Many of you know the Agricultural Research Service at the USDA has 6 human nutrition research centers. And today's speaker that we have is an excellent representative of one of the HNRCs, and that's Sarah Booth, who's director of the John Mayer USDA Human Nutrition Research Center on Aging at Tufts University. So to catch us up on time, Sarah, you could take it away. And thank you for including us.
Thank you. I'm just going to pull up my screen. I'm going to go into, okay. So can everybody see my, my slides? Yeah, okay. First of all, thank you so very much, Holly, for inviting me. And Paul, thank you for actually framing the purpose of this talk today. You did an excellent job. I probably could go to the last slide. I also really want to thank Chris Lynch from the NIH for being here. I consider him one of the architects on the concept of precision nutrition. I also see we have Holly Nicastro, who is also very key to this new initiative called Precision Nutrition. So today I'm going to, in a very, very quick time, do a very, very high level discussion on what is precision nutrition and how can we move it forward in terms of older adults. So there is a wonderful opinion piece that was published last year in JAMA by Doctors Rogers and Collins from the NIH, talking about the importance of precision nutrition. And in basically what they said was, we know, and I don't think I need to emphasize this with this audience, we know it's important to eat well to achieve good health. But we also know from the research that as individuals, there are huge differences in our risk for disease. And I think to Dr. Reed's point, the COVID-19 pandemic really highlighted exposure to one vector. How does each of us vary in our response to that? We also know that among individuals, we all vary biologically in terms of our exposure to a single food. So the concept of precision nutrition is to understand, leverage all the technologies and the new omic sciences to understand how individuals respond differently in order to give tailored advice to promote health. And I think that as practitioners and policymakers in the space of older adults, we are acutely aware of how varied people are when they get older in terms of health. Now, the USDA also is very much embracing the concept of precision nutrition, coming from the angle of precision agriculture. After all, the food we eat are agricultural products. And the USDA has embraced this concept for many, many years, trying to understand, for example, how a plant varies based on its genetic material, the growing conditions, the fertilizer used, substitute plant for human. You're kind of getting the concept that this is a translational approach to how can we refine recommendations in order to eat well to achieve good health. So this is a very a concept that's being embraced across the federal agencies and in the private sector. So what is and what is not precision nutrition? So if you looked at my title, it was enthusiasm before evidence. Have you ever noticed the moment there's a new concept, there's a new app, and precision nutrition is no different. There is a lot of enthusiasm in the private sector for precision nutrition. They're linking your private commercially obtained genetic profile, and they're saying, based on this, you should eat a little more of this, you should eat a little less of that, and also maybe you should throw in a little bit more exercise. This is not what precision nutrition is about in 2021. It's not about the individual yet for the simple reason the data are not there. The research is indicating that we have tools, but it's going to require a very comprehensive, concerted effort across federal agencies globally and with the private sector so that we can tailor nutrition information to promote Healthspan. In other words, it's not about the individual, it's not about you, it's about us. And the NIH is actually embracing precision nutrition, launching an initiative that will draw from the NIH-funded cohort called the All of Us Research Program. Now, in the spirit of full disclosure, you'd think I would have known about the All of Us cohort for a while, but I didn't until last year. And this is this amazing cohort that is being assembled by the NIH, embracing all the concepts that Dr. Reed was mentioning earlier. It's addressing the challenges of inequity, health disparities, social determinants of health, because what they are doing is they are recruiting 1 million people, 1 million adults across the United States to create the most diverse database. They're going to phenotype, genotype. They're going to characterize individuals to better understand why individuals respond differently to the same exposures. And precision nutrition is going to be one of these initiatives that will draw from the All of Us cohort. So I want you to remember that concept of diversity and when we go through this talk. So the actual concept of precision nutrition is summarized here. There needs to be much, much more research, foundational research, which is why those apps are enthusiasm before evidence. We need to understand the role of dietary patterns. We hear about the Mediterranean diet. We hear about different types of dietary patterns like the DASH diet. How do those contribute to optimal health? Certain behaviors, how do they contribute to optimal health? We also need to better understand nutrition across the lifespan. And we as a group are focused on older adults who today have been relatively underserved by the research community, in part because the older adults now span from 60 and up. So you've got now almost 50 years of what constitutes an older adult. Because of medical advances, we are living longer. Also, we want to focus on the reduction of disease in a clinical setting. So particularly the chronic diseases. And these four pillars are then overlaid with the concept of minority health and health disparities. Guess what? Health of men is not necessarily the health of women. We need to look at rigor and reproducibility. We need to do the best science, not small studies and overgeneralize, but do really robust studies that can be repeated. We also need to leverage the data and system sciences and artificial intelligence. I would just argue when I first joined this group, we were in a small room, we were face to face, and look, in just several years, we're already communicating, interacting together through technology. We've got listservs. Take it to a new level in terms of precision, how we can leverage technology to bring a huge group of individuals together and data together to find a solution. There is also an element of training the scientific workforce. This is a long vision, and the more individuals in this field, the more profound the impact will be. So why are we doing this? Well, the reason why precision is so important is what we are doing now is not working. We have a one-size-fits-all dietary recommendation. That is not to criticize the current recommendations. They're robust. They take all the data that we have currently and they bring together guidance. Unfortunately, by its very design, it's trying to simplify when we as a species are anything but simple. And indeed, there's been a lot of emphasis on the number of annual deaths that could have been prevented by a good diet. So we've got to do something different. And to do something different, we have to think differently and we have to think big. So Dr. Reed referenced this somewhat, but I think it's really important just to reiterate that we are living longer as a species. The 85 plus demographic is the fastest growing demographic in this country and globally. But that doesn't mean that just because we are living longer, we are living healthier. Indeed, the number of years spent in disability in this country has doubled over the last few decades. And there's many conditions that our older population are experiencing. The chronic diseases like cardiovascular disease, Alzheimer's disease. We have sense organ diseases, and indeed my colleague Nadine Tessavehi is going to talk about the importance of oral health in aging. We have all these conditions. How does nutrition, how does a healthy diet increase the health span such that the years in disability are reduced? So I'm going to use some examples because if you got to this point thinking, I have no idea what precision nutrition is. It seems like some academic construct that's very complicated. I would argue in principle it is. It's a construct, it's a theory. And now what we're trying to do is bring the data into that construct to move dietary guidance forward. So I'm going to use the example of body mass index because obesity is a problem. We've heard a lot about it in the popular press as obesity has risen during the pandemic. And I want to use this as an example to start framing what I view as precision nutrition with respect to older adults, because I would argue older adults have somewhat been neglected in a lot of the conversation today. So this is a summary, very busy slide, my apologies, but this is Dr. Sue Roberts from Tufts University, the HNRCA, as we affectionately call our center, assembled a group of experts in the building, and we reviewed the data. This is not a formal systematic review. We just wanted to see what is out there about diet, obesity, and chronic disease. And as you can see from this slide, a great number of our chronic diseases, such as osteoarthritis, have been linked in terms of how to slow prevent it with a healthy BMI. So I don't need to tell this audience, healthy BMI is ideal for prevention. But then there's also treatment. And there's some evidence that certain nutrients are very key when people have diseases. For example, osteoporosis. All our osteoporosis medications were tested in the context of having adequate calcium and vitamin D. But there's also evidence that reducing your an unhealthy weight to a healthy weight, from obesity to normal weight, can actually have some beneficial effects for treatment of diseases, chronic diseases. So with that context, we have dietary guidelines. And I know a number of people on the call are very involved in them, and they are the very clear science-based guidelines. Unfortunately, by design, they're targeting, they're assuming a healthy weight. Now, the problem is, as a country, we're not healthy weights. So among people over the age of 60, 42.8% of the population is now obese. So if you are obese, do the dietary guidelines apply to you? And the challenge is we don't really know, because we study people for healthy weight, or we study them obese, but we don't put those data together. We don't really understand how the weight influences the response, for example, biological response to the food. So I'm going to tell you, I had a conversation last week with a clinician from a Boston hospital who was complaining that They were preparing patients for surgery, but those patients were obese and they couldn't perform the surgery until they lost weight. And this clinician who was not in the field of nutrition or endocrinology could not understand how these people could just not lose weight. Well, this is one of the challenges which I think precision nutrition really targets. We see a lot in the media. Low-fat diet, best way to lose weight. Somebody else says, no, it's get rid of the carbs. That's how you lose weight. And when you look at the research and you look at the average change of weight loss, actually low fat and low carb have exactly the same weight loss. They're averaging about 6 kilos over a 12-year period following one of those diets. Now, if you look on the right, if you look at the top graph in blue, you can see that weight loss for any given, that the same diet for different individuals can result in a weight loss as much as 25 kilos over 2 years, whereas some can actually gain under low fat. A similar pattern is seen under low carb. So in other words, we're giving advice based on an average, but individuals are anything but average. And we need to understand what is it about those individuals who lose a great deal, hence low fat, for example, would be ideal for them, versus the ones at the other end who gain weight on a low fat diet. And those individuals will be very frustrated because they can't achieve an ideal weight with the current guidance. This is one of my favorite slides, and I've actually showed it to this team before. Based on current knowledge, we believe that if you maintain the same exercise, so say a 20-year-old woman, and women are indicated here on the orange and men on the blue, and you'll see the overlap of the two sexes in terms of what is their average calorie requirement to maintain a healthy weight. So if you're a 20-year-old and you walk 3 miles a day, and then you get to your 80s and you're still walking 3 miles a day, that between the time you're 20 and the time you're 80, you're probably going to need a quarter less of the calories. And so when you look at this graph, you see the low dotted line, horizontal line, that is the lowest limit of calories, 1,600 calories that our dietary recommendations provide. But if you look, when you get into the old, many, particularly the women, are well below 1,600 calories. So that creates a conundrum for dietary recommendations for older adults, because even though the dietary requirements appear to be lower, we still need to pack in many of the micronutrients. And that is going to require a lot of consideration about dietary guidance, how to get the optimal nutrition in less calories. So the question is, how do we go from our current dietary guidelines for Americans, the My Plate, to a quote, precision nutrition plate? And this is the vision. This is the model. We are going to leverage all these new approaches to collecting data, and we're going to put it all together. And I use the proverbial we, but it's going to require not just a team. It's going to be a global, national and global effort, leveraging technology, science, research, input from practitioners such as yourself and policymakers. So they're gathering data on what is people being exposed to over their lifetimes. Maybe somebody participated, went through wartime, and then were exposed to certain elements and now have relocated to another area. How does the microbiome influence our response? We know from mouse studies that an obese mouse has a very different microbiome signature. The gut bacteria in those animals are very different than those that are lean. We've got our proteome. How does our metabolism vary? How do we each respond differently to given foods? We know about the genome. We have different genetic signatures. How does our genetic profile influence our risk for chronic disease? It's well documented that individuals who have a family history of diabetes, there's a genetic variant. Those individuals perhaps have to pay more attention to certain foods that is going to leverage that risk for developing the diabetes. We even going all the way to social graphs. There's some beautiful, elegant work. I remember seeing this talk from somebody who had actually graphed out the Framingham Heart Study, looking at people's body weight and their social interactions. And they found that people who are overweight and obese tend to segregate with people who are overweight and obese. So our social interactions influence our weight, among other conditions. So I'm coming back to this in terms of the energy requirements, because I want to just put this all together in terms of BMI and older adults. As I mentioned, this is the construct we have now, but the data are not complete. And indeed, we need much more data. And part of the National Institute's Precision Nutrition Initiative will be collecting more data on what our energy requirements are. We use something called doubly labeled water, which adds stable isotopes to water so we can measure directly our energy consumption. The original database that was used to estimate how much calories we need to maintain a healthy weight was compiled from doubly labeled water across the US. There was a new database compiled this year from global sources, including the US. And those data, which have recently been published in a series of papers, have concluded that there's not a lot of variation or change in terms of energy requirements between 20 and 60, after which our calorie requirements decline. Unfortunately, all those data are based on convenience samples, often recruited for larger studies. And unfortunately, there is almost no data on people over 80. So right now, there's a lot of concern the information today may underestimate the decrease in energy requirement during aging. A lot of the populations that were self-selected were healthy. They were active people who participate in research. We're not addressing the inequities of research in terms of health disparities and how different populations and subgroups respond to the same food. And I just want to emphasize that as someone who does conduct clinical trials, you know, clinical trial design has not succeeded in the way we would like. There's part of the reason is we are constrained by the funding mechanism and the amount of funding available. And as a researcher, one tries to create a clinical trial that will answer a question, i.e. exposure to nutrient X reduces risk of developing disease Y. In order to be able to do it within the constraints of the funding, we often select a very homogeneous population. We actually try in clinical trial design to reduce the variability so we can actually see an effect. Unfortunately, this has created somewhat of a bias in the existing data, which is why those apps that I showed you earlier are enthusiasm before evidence. What we need to do is to understand the varied responses is have much larger trials so we can generalize and we can better understand why individuals vary in terms of their response. And that is where the All of Us research program comes from. The Nutrition for Precision Health Initiative is going to be drawing thousands of individuals from the All of Us cohort, which represents the adult population in the US overrepresented for certain race and ethnic groups. There will be older adults in the All of Us research program, and they're going to leverage all these omics, the nutrigenomics. They're going to look at metabolomics. They're going to evaluate ways to assess our diet and then look at diet habits. And they're going to look at physical activity and food behavior in order to understand what drives the variability, with the ultimate goal to give more precise recommendations to individuals recognizing their variability. So I just wanted to give you this very, very quick overview of the topic so that you can understand where the precision nutrition is going. We don't know what it is exactly right now because it's just starting. There's going to be a lot of data collection. There's going to be a lot of discussion. Don't be misled by the current apps. This is going to shift our way of giving dietary guidance. It is a long haul, and it's a collaboration among all of us. And with that, I'm going to thank you very much.